Yeah. November 16, 2023, division reports. Reports and contracts. Mr. Chairman, I would make a motion to consent agenda. All right, and a second.
I'll second.
All right, and a second. Oh, there we go. Thank you. All in favor then of approving the consent agenda, item number 4 on your agenda, please say aye.
Aye.
Opposed, no. Now, Glenn has a long Mr. Chairman, thank you. I appreciate that. We had our first meeting of 2024 this Tuesday afternoon, and we determined that during the legislative session, the trustees were going to try to meet together at least weekly to discuss proposed legislation, how it's progressing. There's items of concern, any changes that might occur in that proposed legislation. And we've included in the packet, you have under tab number 3, the proposed bills and the resolution. First was House Bill number 392. The title of it is Altering Health District Statute Language. And I found this interesting. The paragraph states the purpose of this bill, House Bill 392. It says this legislation modifies Section 39-414 by the code to limit the powers and duties of the district boards of health. That doesn't raise your antennas right away. To limit the power and duties of the district boards of health. Period. It narrows their scope to administer and enforce only necessary and reasonable health laws and regulations, eliminating the broader mandate to do all things in occupational arts for the preservation and protection of public health, including preventive health measures. And that, including preventive health measures, was concerned. What is the intent of those sponsoring this bill? Because we all know that the preventive healthcare measures is heading off issues and problems with the public health before they develop and get out of control. So, but as we read through the actual changes to the legislation, they have crossed out those things they want to change, and then they have underlined the addition that they want to add. And if you turn to the opening page of House Bill 392, you see on line 13, it says, yeah. So House Bill 392, line 13, all along, it says to do, and all is scratched out. It says to do necessary and reasonable things required for preservation and protection of public health. That's fine with me. And it scratches out and preventive health. And I have a question mark where I highlighted it here. And to enter into agreements with direct the State Department of Health and Welfare, and everything else remains the same. So they just added to do necessary and reasonable things required for preservation and protection of public health. They scratched through and preventive health. So we're going to try to get a hold of the author of the bill and find out what was the intent and purpose of this, because we don't see a major change, and I don't think it will impact the services that the health districts provide. But that's kind of a question mark still. And at this point, talking to the Idaho Association of Counties, Kelly Brassfield was there during our meeting, and she said she doesn't know that this will have much traction at all. It's been introduced. We'll see how it progresses, how much support there is in the committees, and that kind of thing. So that's on our radar. The opening purpose statement is raised our antennas, but so far I don't think it's going to be. Next was House Bill 396. House Bill 396. Yeah, that was 392. Okay. And House Bill 392 or 396 is prohibiting mass mandates. And this was a reaction, I believe, to the COVID situation. And I believe a majority, if not all, of the health districts mandated the use of masks in their districts. Panhandle Health District did as well, but then later on, as things progressed, we knew more about what was happening with COVID-19. We decided that we didn't need to have mandated anymore. But as part of the reaction, legislators are saying, issue or pandemic, those kinds of things. So once again, this is a bill that has been introduced. We don't know if it'll gain much traction, but we will see.
Well, two things. One is, first question, do you know how many of the other districts finally have any record of saying we are mandating masks?
I don't know the totals on that.
Because as long as I'm around, it'll be a long, hot day in January before this district mandates masks
Mask
again.
again. Agreed. So,
Thank you. Go ahead.
okay. The next item was House Bill 397. The purpose of this legislation would be to amend Section 39-4803 of Idaho Code pertaining to the voluntary registry of the immunization status of Idaho children, which is kept by the Department of Health and Welfare, to be an opt-in rather than an opt-out registry. When I discussed this with Don the other day before this meeting, we were concerned that might cause more work for the staff of the health district to explain things so that people would understand that you can opt in if you would like. Otherwise, we're not going to put the fact that you have received an immunization or that your children have received the immunization. And if people elect to do that, how are they going to prove as they go to a kindergarten or a daycare or enter into school that their children has complied with the immunization requirements of said facility? So that's a question mark. Once again, this is just being introduced. We don't know how much support there is for it, but that's up on our radar as well. We'll be monitoring what happens with this and whether we need to really bend the ear of our local legislators and let them know whether we support this or not. So another thing to be thinking about. Also, we have the Senate Concurrent Resolution 110. You can find that. This Senate Concurrent Resolution authorizes the Legislative Council to appoint a committee consisting of Senate and House members to undertake a study of the state of Idaho's response to the COVID-19 pandemic. So again, this was driven by the response to the COVID-19 pandemic. As we know, the governor took actions, closed down a lot of businesses, but left several large box store businesses open. Quite a few businesses failed during this time because of those actions. So it was seen as detrimental in a lot of ways. But again, we don't know how much traction this will have, but I don't think it would be a bad thing to evaluate the response of the state and its agencies to the pandemic. So we'll see how this proceeds. I know the sponsor of this bill personally. I worked with him for probably 10 years with the Alaska Air National Guard. So anyway, I'll keep in touch with Senator Dan Foreman and see how things go. The Senate Bill 1227 and that one. The stated purpose of this legislation creates a revised section to Chapter 90, Title 39 Idaho Code relating to health rights The revised section is to be known as Section 39-9004. This section establishes health rights under the law for medical patients, their family members, and legal guardians. This legislation will help ensure fairness of treatment, enhance patient awareness of medical treatment options, and install patient safeguards with respect to requirements for informed consent and the use of experimental drugs. I think those are all good things. This legislation will place necessary and expected restrictions on state and local government as to governmental authority with respect to the advertising of certain types of medicines or vaccines and the imposition of personal restrictions on Idahoans relating to widespread medical situations. So, in the proposed addition, new section is included here. If you'd like to review that and give us your inputs and suggestions as well. And again, this is just being introduced. We don't know how much support it will have, but we'll monitor that and keep you advised as things proceed. Okay.
So it's my understanding that none of these have really been discussed in committee yet.
Correct.
So there's no need of us discussing them because they may.
So many
pass
things
away
die in
before we have a
committee
chance to see them again.
But they're on our radar because they're being proposed. So we will monitor it and keep you advised as things progress. Did you have any questions for me? All right. Thank you, Mr. Chairman.
John, about the Idaho Association of County District Boards of Health.
Yes. As I think everyone here is aware, on an annual basis, the Idaho Association of District Boards of Health gets together for a 2-day conference. And this last conference was held here in Coeur d'Alene, and District 1 hosted that, and people really appreciate the opportunity to get together to review health issues and policies and procedures and techniques. And it's been a good event. And we rotate that among the 7 health districts. And this next year, it will be with District, is it 7? Down in Idaho Falls is where they normally hold their convention. And the chairman, Brent Mendenhall, this year said, you know, most of us are very busy in the month of June, the second week of June. We would like to see this whole convention shifted into the fall timeframe. And so they proposed that we hold this during 23 and 24 October. That would be a Wednesday and a Thursday. And we'd have a discussion of the location. But it would be somewhere probably in District 7, because the conversation said we enjoy being able to go and see the different areas of Idaho and their districts. So we supported the idea that it be shifted into October timeframe. I objected somewhat because that's the elk season, but they said, well, take up archery and get your elk in September. Well, I've tried that for quite a few years. Anyway, they're going to shift that into October. So and that's all I have.
Okay. I don't know that we want to follow for too much discussion unless you have something really strong, one or the other, that you would like to share with Glenn.
Yeah.
June versus October Any strong feelings?
How many would support that? Ooh,
Oh,
I think I would. Huh?
I don't care.
You don't care? Okay. So,
And Mr. Chairman,
Yeah.
those travel expenses are paid for by the health district as well, if you're interested in attending.
okay.
well, thank you, Glenn. You have been busy at your post, more so than a lot of months.
That's no problem. Being retired is fun.
Oh, yeah. If I'd known how much fun retirement was, I would never have gone to work. Okay, now, item number 6, I'm going to start with Dawn and let Dawn introduce Kim for us, and then Kim will take it from there.
All right, thank you, Mr. Chairman. So every 5 years, the Panhandle Health District conducts a community health assessment.
And that's this item right here.
That's
Yes.
correct. That's the outcome of the one we've done this year. And when I say Panhandle Health District, I'm really meaning a number of community partners in all 5 districts contribute to this CHA, as we call it. And this is very important for the health district because it gives us direction of where we should go. Understanding this is the public saying to us, what are the greatest health needs in the community in which that we live? And so Panhandle Health District structures their strategic plan and objectives associated with what comes out of this community health assessment. This year we did something different. In the past, we actually did we completed this CHA as we did 5 years ago. This time, for the first time, we actually contracted out or outsourced that work to a company called Crescendo. Not only did they do a better job than we did, but it was much cheaper than us conducting this CHA on our own. And you'll see on your screen Caitlin, and she's going to be giving you an update. But I also wanted to say the CHA is the first step. The second step is completing what we call a community health improvement plan. So it's our plan to address what came out of the CHA. So I don't want to steal too much thunder on this. I just wanted to give you that background to this and how happy we've been with Crescendo. Kim Young has had the responsibility to oversee this, and I know that's been a very time-consuming project for her that goes back over 6 months ago that we began this process. So I indeed want to thank her for all of this work. So with that, I'm going to turn the time over to Kim to add anything she wishes to on this, but also to introduce Caitlin.
Sure. Thank you, Mr. Chairman. Thank you, Director Duffy. Yes, I'd like to introduce Caitlin Mashad. She has been wonderful, her team, in conducting all of the focus groups, the interviews, the community survey. Hopefully you've all seen that. I did talk a little bit about it at the last Board of Health meeting. She is the managing principal for Crescendo Consulting Group. So with that, I think Dawn really covered it all. So I am going to turn the floor over to Caitlin for her presentation today on the community health assessment and the outcome.
Great, thank you, Kim, and nice to be here all in your meeting today. So thank you for giving me some time to present the findings of the community health assessment, or you might hear me say CHA as well. I'm going to pull up a slide deck I have here, but I'm excited to see you all have, looks like, copies of at least the executive summary, if not the full report with you. So certainly recommend at least browsing through that at some point, because there's going to be way more data within the full report than what I'll be able to present to you all today. Okay, come on. Okay, are you all seeing a slide deck now, just to verify?
Yes, Caitlin, we are.
Okay, great. You would think by now I know how to use Zoom, but every time. Okay. Okay, come on. There we go. Great. So we're going to spend the next kind of 20 minutes or so going over some data here today. I'm going to ask you to wait and hold your questions to the end when I can stop sharing my screen and see all your faces in the room again. But today's discussion, our kind of agenda, if you will, for this presentation is just a quick review of goals and objectives of the community health assessment, overview of the methodology, so what we did to get to the conclusions that we have today. Then I'll show you some key highlights of the secondary data, the key qualitative research themes. So based on all those focus groups and interviews we did with folks, kind of some of the themes that we discovered, also a few quotes as well from community residents. I'll show you a few key survey results, and then we'll review the top needs and talk a little bit about the CHIP process and next steps. So what are our overall goals for doing a community health assessment? As Dawn was talking about, it is a regulatory requirement to do these every 5 years, but outside of the regulatory requirements, there's two main goals and objectives for doing these needs assessments. The first is really to understand, especially in light of COVID in the past, I don't even know how many years we are at this point, but there's been a lot of changes largely due to a lot of impacts of a global pandemic. We had a lot of inflation over the past years. The housing market, and I know especially in Idaho, has just gone bonkers. So there's a lot of things that have been changing in kind of real time and recently that very much impact someone's health. So it's a great time to do a needs assessment to really understand, what's changed in the recent years. How is this impacting our residents that we serve in the Panhandle? So it's, again, the goal of the Panhandle Health District is really to improve the lives of the residents in the area, especially health focused. So we need to understand root causes, what's going on in a community to really be able to impact their overall health and especially health outcomes going forward. So within this project, we look at a lot of issues, trends, disparities within the region. Our second goal here is, again, the regulatory requirements, but it also helps with the planning aspect of, the health district does a lot of things, but are they doing the things that the community residents need? So it's an opportunity to really look at your current service lines, if you will, and see, is this what the community residents need, or do we need to refigure or think about new opportunities as well and what that means? If we're thinking about new programs or new services that the health district might offer, that could also mean needed grant funding. We might need more resources or people to run these programs. So it's an opportunity to think about, again, the organization, agency level, what you might need going forward to really address the needs of the larger population that you serve. So what is our methodology to get to our results? So the way we approach doing needs assessments is through both a quantitative and qualitative approach. So we start first generally with the quantitative, looking at secondary data. So this is data that is typically publicly available. I know PhD provided us with some internal data as well. It's secondary data is great in the sense it helps us set a baseline of who our community is. We look at basic population, demographic, housing, health measures, really anything that's out there. But one of the challenges with secondary data is sometimes the data is a few years old. At the time of we were working on this project, the most recent data available we had, at least from the U.S. Census Bureau, was 2021. So you can imagine that, we're in 2024 now, but 2023, the data was at least 2 years old. So there's been a lot of changes within those past 2 years. So that's why we also really focus on the qualitative work. So these are those conversations we have with community members through interviews, kind of one-on-one with individuals, or in focus groups or kind of group interviews, and also community survey, because this allows us to collect primary and more real-time data that we don't have otherwise. So as far as the qualitative research goes, we conducted 23 one-on-one interviews, and this is across the 5 counties that PhD serves. We also held 9 focus groups. Most of them, I think about 6 or 7 of them were in person. The other couple were virtual focus groups. And we met with over 50 community residents, participated in those various focus groups. Again, we held at least 1 focus group in each county as well to make sure that we had a diversity and voices heard, knowing that each county is a little different as well. I mean, it's important for us to understand the differences between the counties. And based on the qualitative research, we found 5 overarching themes, which we'll talk about in today's presentation as well. We also conducted a survey. One of the challenges we have with qualitative research, it's really hard to quantitate it. You can't really quantitate what people tell you because we also ask kind of leading questions. So we can't really go into our research notes and count how many people said affordable housing because we also ask people about housing. So one of the ways that we're able to quantitate to some degree the qualitative research, really validate it and really check on the magnitude of the need. Because there's going to be people in your community that are going to be on their soapboxes of an area that they're very passionate about. And they might be the loudest person in the room. And it could be just, again, a small subset of the population where this need is big versus the whole population. Or again, this need could particularly be across the board in all counties for all populations. So the survey allows us to dig into that a little bit and have a better understand the magnitude of need throughout your county, or if it is a little more geography or population specific as well. So we released the survey in both English and Spanish. It was available online and it was available paper-based as well. Hopefully a few of you in the room might have taken that survey as well. So we typically leave them out for about 3 or 4 weeks and then we crunch all the data. After crunching and analyzing the data, we had 783 valid survey responses, which is pretty good. We've worked with other clients that not so good. So good job on that. And then based on the research, that really wraps up the research phase of the project. And then we identify all these needs. And we did have a very long list. We tried to get as granular as possible to really understand specific needs in the area. So we had a list of 44 community health related needs or service gaps. So then we worked with the kind of the subset, as we call it, the leadership group, which were members of kind of the PhD leadership team here and also a few key community partners. So we worked with that group to really identify of all those needs, what are our priority areas? And we were able to narrow down that list of 44 needs into broader kind of priority groups or categories, if you will. So at the end, we had 6 of them. And then based on working with Don and Kim, as we go into the CHIP process, the PhD is going to focus primarily on 3 of those 6 categories. We'll talk more about that coming up as well. So now we're going to jump into some data. We have just a few slides here to show you some of the key data. You'll also see this in the executive summary of the report as well that you might have next to you. So one of the ways we like to approach data is through a model that the CDC developed actually after Hurricane Katrina to identify within large populations such as New Orleans, what are some of those subpopulations that might be more vulnerable to potential natural disasters like a giant hurricane, or you could look at it, I think you all probably got to experience those Arctic cold weathers that most of the country had over the past couple of weeks here, the negative 50 million degrees and wind chill going on. That can be considered a natural disaster as well for probably some of the southern states that aren't used to that cold. I know you guys are used to it a little bit more. And also COVID, things like that. So these are some of the measures that we look at to better identify vulnerability within a larger community. So this table is really more focused on social economic status. There's other measures that go into this as well, such as age is an important one, such as housing status, whether renter or if they're in home ownership, if they have a vehicle. So there's other measures as well that you'll see in the report. But what's interesting, and I'm sure no surprise to all of you if you live in the community, that there is quite a bit of disparities or some differences between the 5 different counties. Obviously, Kootenai County is the largest population in the county with about 170,000 folks that live there. And you have Bennewauk County with just under 10,000. So quite a variation in the size of the population. There's also a decent variation in the percent of the population that lives below the poverty level. So you can see, if you can see this from where you're sitting, the highest population is living under the poverty level, and we're talking about 100% federal poverty level. So these are very low income folks. And these could be seniors living on a fixed income. So these could be seniors on just Social Security. It could be young families. It could be working folks as well. So it really could be anyone if you think about it. But in Boundary County, you're looking at about 1 in 5 individuals that live in the county live below the poverty line. It's about 17.3% there. Versus Kootenai County, it's 9.2, so about 1 in 10. So you can see that's kind of a big difference. And then certainly Benewah County is pretty close, along with Shoshone County, with about just under 15% of the population living in poverty as well. So you can see some of those potential differences and, again, maybe opportunities, rural versus maybe slightly more urban in Kootenai County, since you have a larger population there. So there's a lot of things that could play into why there's a higher poverty level. Certainly employment opportunities is a big one as well. Looking at unemployment rate, again, this one's always outdated as soon as you publish it, because Labor of the Bureau always publishes it on a monthly basis. But when we pulled the data, 6.3% unemployed in Shoshone County. So again, maybe there's lack of employment opportunities there. So there's a variety of reasons that could go into that, which also plays into median household income. As you can imagine, it varies widely across the community. With Kootenai County, is about $65,000 is the median household income. Which is right around Idaho as a whole. But if you go down to Shoshone County, it's about $20,000 difference, with the median income about $43,000. So that can be a drastic income difference there. Going to my kind of bottom right-hand corner here, one of the interesting trends is, as I'm sure you all live and see this in the community as residents, but there's quite a difference in age. And I know over the course of kind of the recent years, COVID, the huge influx of populations moving into your area. I know some counties have a lot of retirees. You're such a beautiful area. I can see why people might want to retire to the community, live by the lake, enjoy skiing and hiking and all the water sports. But this also can cause some demographic changes and also needs of services. If you look at the bottom right-hand corner, we're looking at total age groups. So we have it broken down by under 18, and then 18 to 64, then 65 and above. So you can see in Bonner County that 1 in 4 individuals that live in the county are 65 and older. So again, likely a lot of retirees, and that could mean they might have different health needs going forward. They might be more needs for specialists. There could be need for more memory care, or in the future, assisted living. So again, this could change, again, demands on the health system in the community, and also social services as well, and thinking about housing. Our next slide here, looking at a couple of health-related data measures here, looking at overweight versus obesity. We're looking at the Panhandle Health District versus Idaho State. With both of these, you can see as far as the overweight prevalence rate, which is the left-hand graph here, PhD service area is about what the state average is here, and it aligns pretty well with the U.S. data, which is not shown here. So about 65% of the population is considered overweight. If you go at the right-hand chart, you have obesity. So you can see Panhandle's faring a little better in that sense than Idaho as a state. What's really interesting with the chart, and it's a little more dramatic with the obesity rate, but you can see it a little bit in the overweight prevalence rate as well, that, from 2016 to 2019, you could see there is actually a slight downward trend where, maybe people are getting healthier or maybe not as overweight or obese, but you can see as we go into 2020 and into 22, where we have the most recent data available, is that you're starting to see the trend upwards again. So there could be a variety of reasons why this is happening. My guess, again, due to the influx of the new people moving into your community could certainly skew the data. COVID, people just not going outside, not being active, maybe not eating the most healthiest foods. So there's a lot of reasons that can go into why we're seeing some upwards trends on that. So it's something to just kind of be mindful of going forward in the coming years. Are we seeing a continued upwards trend, or will we see a decline? So it's just kind of an interesting point to look at. This measure here is suicide rate, and I apologize, I should have a data label on that. So I will correct that before I send the final version to Kim. But one of the big themes we heard a lot about in qualitative, and I'm sure it's no surprise to many of you, is really the impact over the recent years in behavioral health, mental health especially, that, you know, the acuity of a lot of depression, anxiety, even some of the more schizophrenia, a lot of kiddos really suffering as well, a lot of emotional kind of PTSD coming out due again to COVID, being isolated, that there's a lot of, we're in crisis state, if you will, across the country for mental health right now. We just don't have enough providers. We'll talk a bit more about that coming up from the qualitative research and even some of the survey. But again, looking at the secondary data, again, I know this is a very busy chart to look at as we have quite a few years worth of data. But this is suicide rates by county and then by the health district in Idaho. And there's some interesting trends here, a little concerning as well, knowing some of these counties are a smaller population. But you're seeing in some of the more rural counties here, Benewah County, Boundary County, Shoshone County, you know, have a slightly higher suicide rate than, say, Bonner County and Kootenai County. Certainly Shoshone's more of the outlier in the sense it is overall a little higher compared to some of the other counties. So it's something to be mindful of. Why is suicide rates higher? What's good to see here is that we are seeing, it looks like they peak, if you will, around that 2017 to 2019. And they have started to decline from 2020 to 2022. So that is a good trend that we're seeing, but it is, you know, we want to dig a little deeper into, is this still the case going forward? And also consider why we might see some of these differences in some of these maybe more rural counties where opportunities are less. We know that poverty rate's a little higher. You could look at it by age groups. So there's a lot of things going into this, and maybe it's access to providers. You know, are there mental health providers in this community? Is stigma a challenge? So there's a lot of things you could dig into this. So this is just kind of one of those measures or indicators that you could just kind of keep a pulse on to help better understand what mental health or community residents might be in the community. So now we'll transition into the qualitative research. As I mentioned earlier, based on all the interviews and the focus groups we conducted, we analyzed all our notes from all those conversations and really looked at themes. What did most people talk about? What seemed to be trickled to the top as the biggest challenges for the wider population, and also maybe some of those subpopulations where it's more critical. So the 5 needs here we identified are the themes. The first one, again, these are only in alphabetical order. They're not in any kind of prioritized order here. But the first one we have here is accessible public transportation. Again, as you all know, driving around the roads in the community that you live in, everyone largely needs a vehicle to get around. We know there is some limited public transportation more in the populated areas, but if you live in Boundary County, the chances of taking a public bus down to the grocery store is probably pretty slim. So you really need a vehicle to get around. But we also know, especially as people age or maybe people with disabilities, that they might not be able to drive. So what are those opportunities for those individuals who don't have a vehicle or are unable to drive anymore? How do they get to their medical appointments? How do they get to the grocery store? Because that can very much impact their health. The next one, which is a big one, and I know this is a big bucket as well, but appropriate and accessible healthcare services. So we're talking more specific to your traditional physical health care, dental care in this sense. We have a separate one here around behavioral health, but certainly behavioral health would fall under accessible health care as well. Again, This isn't necessarily unique to the Panhandle or Idaho. There's a lot of places across the country, especially more rural communities, that are really struggling with provider access. There's a shortage of lots of different providers, especially when you get into specialties, where a lot of people said they had to drive to Spokane to go see XYZ just because there's no one in the community that treats what they might need. What is concerning, and I'm sure no surprise to all of you, especially in recent kind of news and events, is OBGYNs are becoming a lot harder to find in the Panhandle because a lot of them have already left the state due to some political changes. So that's certainly concerning, especially for a lot of young families, that they might not be able to be, babies born in northern Idaho, which, or if you also think about if a pregnant woman needed emergency care, could they go to ED and get appropriate care, or would they have to be life flighted or transported out of the state or out of the area for treatment as well? So there's a lot of concerns around some of the specialty care access. This is, again, also very much tied to a person's insurance status, their ability to pay, and even transportation as well. Third is housing stability. Again, with the influx of a lot of new folks into your community, it's really driven up costs of housing, which impacts a lot of people that lived in the area for a while, or those that might be considered working class, if you will, that, housing is becoming unattainable for a lot of people, both from the rental side of point and home ownership. So a lot of people's, income each month is being, they're paying for housing. So what's left over for food? What's left over for childcare or gas to put in their vehicle to get to work? Or even, can they afford to go to the dentist? Can they afford to go to the doctor? Or are they now putting that off because they can't afford it, because they're trying to put a roof over their head? And some people just aren't living in healthy homes either. So there's always that impact that could impact someone's, let's say, asthma, or lead poisoning for kiddos. So things like that, housing can very much impact that. But what we heard mostly about was just the affordability of housing has just skyrocketed in the community. Next one is shortage of behavioral health services. As I mentioned, the acuity of behavioral health across the country for really all populations, especially youth and any older adults as well, is that we don't have good access across the board. We don't have providers. We see this especially in a lot of psychiatrists, a lot of the prescribing providers in the community. It can be hard for people to get the medications they might need. And crisis care as well, and inpatient services is very difficult as well. If someone needs to, stay at a safe facility, that their options are very few and far in between for those inpatient beds. And most of the hospitals in the area aren't equipped to handle a lot of, especially high acuity behavioral health patients. And last but not least, we have youth specific services. So we had quite a few community members talk about the need for youth-focused services, and this can be anything from childcare, affordable, accessible childcare, so the parents could work, and that youth is in a safe place. This could be after-school activities, health education in the youth population, a lot of the developmental needs, especially the young kiddos that might have started school with it, during COVID years as well. Many kids, especially young folks, aren't hitting their developmental milestones. So what does that mean for them going forward, and how will that impact their lives? So here is just a few quotes as well. I can read them off for you because you might not be able to see it on your screen. I just wanted to pull a few quotes again from your neighbors, your community residents, and those who participated in this project. So we have one that's kind of around access of care here. The person said, "It's hard to receive any continuity of care here. Keeping providers here over the past 2 decades has been a massive challenge." So again, this person's talking about the need for more providers. It's difficult to, once you have someone, they might change, and then you're looking for a new person. Impacts of housing costs. It's all connected. The kids are covered by insurance, but the parents don't qualify. I'm assuming they're talking about kind of like Medicaid. If the parents do get sick, they end up with a huge debt, which makes it harder to find housing and afford housing. It makes everything else harder. So again, you can see that impact of just housing costs and the ability to pay for other things. And one sickness could leave a family on the streets. We have behavioral health demand. There's no inpatient treatment out here. There isn't significant crisis management. There's not enough behavioral health in our area to meet the need. And then youth needs. Since the pandemic, youth mental health has declined tremendously. Youth are very affected by the isolation. Some kids are too anxious now to go back to school or get a job. So again, also tied to behavioral health. And there's many more quotes as well within the larger report as well. So if you're interested to hear more about some of the things that your community members said, then certainly take a peek at that. I just have a couple slides here on the survey results to give you a sense of some of the high-level findings from that survey. Again, there's many more data tables and conclusions within the report on the survey. I'm starting high level here on the right-hand part of my screen, just the top 3 health-related or social issues that people ask. One of the questions we asked in the survey is, we gave people essentially laundry lists and an option to provide their additional thoughts that might not have been within the question. What are the top needs in the community? About 75% of the people who took the survey said affordable housing is number 1. So 3 out of 4 people who took the survey said affordable housing. Very close on its heel with 70% is mental health, including suicide and depression as kind of the second biggest need in the community. And then about 50% of the respondents also indicated illegal drug use, abuse of prescription medication, and alcohol abuse, again, as one of the big needs in the community. So you can see really those top 2 out of 3 health-related issues that was selected by survey respondents were related to behavioral health. Going over to my left-hand part of the screen here, again, one of the questions we asked the survey respondents is, within the past year, so within the past 12 months, has there been one or more occasions when you needed medical care but chose not to get it? So about a third of the total respondents, so again, 1 in 3 people said, yes, I needed care, but I chose not to get it. And there were a variety of reasons, mostly around ability to afford the care. Some of them also answered transportation or long wait lists to get into providers, but overwhelmingly it was related to a person's ability to pay for services. And there is a difference if you look at the bottom table here between the counties as well. So you can see within Boundary County, of those 1 in 3 people that said, yes, I needed medical care, I chose not to get it, 43% of them were from Boundary County. And you can see the smallest number was actually in Benewak County, where it's about 27%. So there's some differences, looking at it, I couldn't quite make any conclusions on, maybe the more rural counties were more difficult versus the other, but it's just kind of interesting. I know some of the ends on these counties, the number of folks who reside in that county are smaller compared to maybe Kootenai County. So the data might be a little skewed in that sense, but it's interesting to look at potential trends. My second slide here, again, just kind of continue on that. In the top left-hand corner, we have dental care. So 1 in 4 individuals said, yes, I needed dental care, but I chose not to get it. Overwhelmingly, again, related to costs and also just finding a provider that had availability. The bottom right here is mental health. So again, similar to dental, about 1 in 4 individuals said, yes, I needed mental health care, but chose not to get it as well. Again, often related to costs and also awareness and availability of providers, because we know there's not enough mental health providers in the community. So at the end of the day, what are our prioritized needs? Where do we start addressing some of the needs? So the way we look at the needs prioritization process, we did it in 2 phases with our leadership group. When we first conducted a short survey, everyone in the leadership group took it, which helped us kind of narrow down the list, if you will. And then we had a meeting where we discussed this, of those 44 needs, how can we maybe make them into broader categories? Because having a list of 44 needs, if I presented that list to you all saying, okay, there's 44 needs you need to address over the next 5 years, your eyes would probably shoot out of your head going, oh, that's a lot. So we work into slightly broader groups because many of those needs are actually very much related to one another. So at the end of the day, we identified 6 priority need categories. So we have access to care, behavioral health for youth and adults, diversity and inclusion, older adults, social determinants of health, and youth services. And you can see within each of those categories, there's about anywhere from 1 to about 4 kind of subcategories or identified needs under each of those. And that should be on one of the first few pages of the report you have, so you can probably look at it and see it a little better than up here. So what's next? We have this lovely report for you all with all this data. What do we do with this? As Don says, we are now working on our community health improvement plan. So the way you can look at this, also called a CHIP, it's really like a roadmap or a strategic plan, if you will, that's focusing on the community. Based on these needs, how are we going to, as an organization agency, address these needs so we can improve the health of our community? So based on kind of what Panhandle Health District's good at, what your current resources, your current capacity are, the leadership team selected 3 of those 6 priority need categories to focus on over the next kind of 5 years. So our 3 categories is access to care, and this includes things such as provider availability, including both primary and specialty care, mobile outreach programs, knowing again that your community is a large geography area, also very rural, that they can't always come to you because we know people have transportation barriers. So maybe there's opportunities, you go to them. Transportation and then costs of services are all barriers to access to care. Our next category, behavioral health for youth and adults here. And this can include things such as mental health provider availability. This also means, too, there might be providers in the area, but they might not accept insurance. So maybe there's opportunity to try to work with those providers to take insurance and not just private pay, which might be unaffordable for many of your community residents. Crisis intervention, too. How can we better help someone in a crisis? Substance use prevention, early intervention. We have recovery services, mental health education, prevention, early intervention. So behavioral health is kind of a big bucket there, but we certainly know it's very much needed. And then we have youth services. So this can include things such as childcare, which also includes after-school care, health education, and services for youth experiencing housing instability. So they might not be fully considered homeless by HUD's definition, but they might not have a stable housing. Maybe they're couch surfing with friends. So a lot of opportunities here for the next 5 years. And as far as our next steps, again, we are working with Kim and Don and the team right now working on the CHIP. So I'm sure you'll hear more about that coming up in the coming months as we kind of dive into this a little deeper and think about potential strategies and solutions that PHD can use to address some of these needs. So as far as the process, what we're working on, we have key informant interviews, which one of my team members is, I think, largely done with that, which is great. We're also going to do a survey as well. We're doing a literature review, which is not listed up here. We're doing a strategy session as well. We're going to do a virtual meeting with a bunch of people to walk through of the potential strategies. Where are we going to start? Let's start developing essentially that strategic plan so we can move that dial in a positive direction on some of these needs. And then we'll have a CHIP report for you all as well so that you can dig a little deeper into this as well. And that is my presentation. Hopefully I'm on time for you guys as well. So with that said, I'm happy to take any questions.
Okay, that's quite a report. You have any burning questions you would like to pose? And I suppose, Kim, you can help with the answers also, maybe?
Possibly.
Okay. Any comments? One of the things I'm assuming, we board members represent different counties. And so the first thing we want to know is, what are the statistics for our county? And at least that's, and when I was looking at this, Benoit County, population-wise, is the smallest counties of the 5 counties. But I don't know why that means then that Benoit County has to have the lowest number of high school diplomas, percentages of high school diplomas. And I don't have an answer, and I don't suppose anybody else does. But I have some reasons, but I'm not going to voice them here.
The trend we see is because of the industry, the mining, logging that don't require diplomas or further education. Tend to,
CDL, drive.
tend to want to follow their fathers, grandfathers. I'm going to go mining. I don't need
Family
a diploma.
And then I also noticed, going to Benoit County, the suicide rate caught my eye. And there again, I'm not going to comment. But that does consider, yes.
I have a question. I was a little bit confused by the information concerning access to medical care and the did the patient desire it? I mean, in other words, it seems as if some didn't necessarily desire it, so that isn't necessarily a deficiency. So can you elucidate that point a little bit? I'd appreciate that.
Yeah, no, you're certainly right in the sense of kind of the motivation piece that, someone might need care, but they might not be motivated to go. We do see that in certain populations. Typically tends to be more male that might not go to the doctor. There's evidence to support that at least national level. But yeah, the way we formulated the question is that we asked them first, like, did you need medical care or dental care or whatever the question was, and chose not to get it. If they selected yes, there was a follow-up question that asked them why. It gave a bunch of options. I can actually pull up the report and show you that section give me a second to do that. I just need to get out of the screen. Uh-oh. But I can show you more data on that in the report because you might not have all that. But the way the follow-up question, it gave them about, I think it's 10 or so options, again, saying, why did you choose not to get care? And I think most people, again, selected largely, sorry, I can only do one thing. Again, it was largely around affordability of care. They're able to afford to go to the doctor. Yeah, let me pull this up here. I will apologize. It's going to be probably very small, but I'll make it bigger. Okay, so this is the mental health one, which is actually a little different than traditional medical or dental. Because again, I think this goes to your question too, that maybe they're not motivated. And we see this a lot with mental health, especially. There's a lot of stigma tied to mental health and people not wanting to seek care compared to traditional. So in mental health here, this is the adult population. We did ask a similar question for parents with young kiddos as well. So we see in the adult population that of the people who took the survey, essentially 1 in 4 said, yes, I needed care, but chose not to get it. Again, reasons for not seeking care. Overall, we can see that about 40% of them selected unable to afford to pay for care. And again, this was a check all question, so there could have been multiple reasons why they chose not to get care as well. But a third of the respondents said that they're unable to schedule an appointment. So again, it could be related to wait times. It could be they couldn't take time off for work, which is actually the third reason here. About 20% said, I cannot take time off from work to go to an appointment, which is a common reason a lot of people choose not to. And then we do, one of the needs or one of the reasons at the bottom here, about 9% said that, again, going back to the stigma. So family or friends might think poorly of me if I choose to seek mental health. So it doesn't specifically ask about motivation per se, but yeah, that certainly plays into it too as well. So whether the, lack of going or motivation to seek care, whether it's kind of intrinsic inside the person or extrinsic in that sense of ability to pay or transportation, certainly could play into it. So, it's certainly not a perfect question. It's not a perfect reason, and we won't, I think, fully know why someone might not seek care, but the biggest barriers we identified really was around ability to pay or time off to seek appointments or transportation.
And I also noticed that, inability to find or, et cetera as well. And because I know from the mental health, capacity, I mean, from our the medical practice that I have, there are not a huge array of mental health practitioners that are readily available at a reasonable cost, and there's a lot of different approaches that are taken. But the other reason, I mean, but that was in the mental health realm. Did you ask that same question for just regular healthcare per se?
Yeah. Let me pull that up. It's mental health, that's dental. Let's see, I want to make sure I'm getting you. Okay, so this is medical care here. So we can see about 1 in 3 said yes and chose not to. Right. Okay, here's the overall. We have it broken in tables by county as well, but 55% said lack of money, ability to pay, 42% long wait times to see a provider, 23% lack of health insurance, likely related to payment, 22% did not feel comfortable with available providers. So again, that could play into it. It's largely again related to payment, wait times, access to providers, might not like the options available to them. Or again, we have one, about 12% said doctor's office is too far from my house. So again, could be related to transportation.
Another issue that I think is important to point out is that the fourth one down, because of a lot of the things that are related to the House bills, et cetera, there are a substantial number of people who feel uncomfortable with the way healthcare has been managed in the last few years, that they feel a degree of distrust from the point of view of we're being mandated or forced things. I don't want to necessarily go in and be told that I can't receive care unless I have a shot, unless I comply to this or that, et cetera. So I know that the trust issue is partially self-imposed by the medical community itself. In other words, we used to have choices with healthcare, but a lot of what we've converted to in the last few years are, in essence, no, you don't have a choice. You're going to get this. This is protocol. And I know a lot of people are saying, I'd rather not deal with it. I need it, and I choose not to. And so I think that's an important point. It's not just financial. If we miss that point, we're going to be missing a lot of people. Is my point there.
Yeah, no, I think you're right. And we did hear similar to what you were saying. We heard some of that in the qualitative work. I think we're not seeing that as much in the results of the survey because I think playing into similar that distrust or not wanting to seek traditional healthcare, we probably didn't hear from those people in this survey. They, again, likely chose not to take the survey. So the people who completed the survey are probably more likely to seek maybe healthcare. So there's probably some bias in that sense that we don't really have a strong voice of people that might not seek health care. So I think you're right, because we did hear a lot of similar things to what you're talking about in like interviews and focus groups, that there's a lot of mistrust or distrust, or I know there's people that move to your area specifically because they want to be off the grid. So there's kind of that already culture in there that predates COVID and things like that too.
Right. I think you bring up an excellent point, Caitlin, because somebody who's going to subject to a traditional healthcare survey is not going to be necessarily resistant to traditional healthcare per se, but alternative medicine has exploded, and the naturopaths and the alternative medicine, the functional medicine. I mean, people have shifted tremendously to that pathway because of that, and they're not reflected here. I mean, is kind of a very important point. I mean, I'm not trying to make a big point, but if we only think that it's financial, I think I'm missing a lot of people.
Mm-hmm.
Wow. Caitlin, Kim, I can see where this could open up the door for hours of discussion and questions. Do you feel that way? Okay, let me just give a last moment here. Dr. Jameson, do you have a comment? That we don't want to forget about you because you're not here in person, but what are your reactions?
I think I would just second that. I mean, I completely agree that a lot of the challenge here is going to be selection bias of the people that are answering. And not that it's not a valid survey, but I agree that we just have to keep that in mind, because I think there are a lot of other variables that play into the answers and then the things that we're getting, and much of that was just wonderfully explained, I think. But the other challenge I think you're going to run into is, we do see that we have a hard time recruiting physicians to this area. They come out of school with a lot of debt, and they are having a hard time finding. We just lost an ENT doctor for this reason. They couldn't find anywhere to live that was that they were able to afford. And so, to be able to recruit is one thing, and then to be able to retain is a whole nother challenge that I do see that we face in this community.
Okay, Tim, let's go to you. Did you see anything there that regarding Boundary County that caught your eye that you would like to see changed or improved?
Well, one thing I saw was the fact that Boundary County is at the top of the chart on a lot of these categories. And so they're going to have to be addressed in one way or the other. But good information to work off of.
Indeed. Any other questions or comments before we move on? But sure, thank you. And obviously there's been a whole team of people who've been working on this, right?
Correct. Yes, we've had Director Duffy, Kate, myself from PhD, and then we have someone from every single county that's on the leadership team. So not everyone's been able to attend every single leadership meeting, but we have representation from every county. And we'll do so moving forward for the CHIP process as well. We haven't really sent out the invite. We've sent out the invite, but not the invite for the actual workshop yet. We're getting there.
Okay. Is there anything else now either you gals would like to say in conclusion? If not, we'll wind this up. But where do we go from here?
We'll be starting the CHIP process, and then hopefully have a report for you coming up in the next few months. Once we get that solidified, I'm working on our strategies.
Yes.
If I may, Mr. Chairman.
Yes.
So one thing I have to acknowledge is that the cost of this, Kootenai Health contributed $7,000 toward the cost of this survey, and we're so grateful for that. And part of it is because they are now, as they're becoming a non-for-profit organization, they are required to do a community health assessment. And again, just to let you know, we appreciate their help with that. Also, I would say that once we're completed with the CHIP, Kate, or Kim and I, and others, Kate as well, we hope to get out into the community and spread these results to whatever organization is willing to listen. So this is a plea to all of you. If you have anyone, we'll go to any group and talk about this. I think it's important to have even a broader community buy-in than what we already have.
Well, Glenn, make sure, this is a fun here, but make sure that some of these legislative proposals don't prohibit us from doing this.
Oh, yeah. No, there's some badly needed services, I think, that are identified that
Right.
we've got to be able to do that. Preventive care.
But with just a first glance over these things, it gives the appearance that there are some people who want to clip our wings.
Yeah, we've got to get more information and figure out what was your intent here. And I think that will answer some of those questions. So we'll reach out and try to find out.
All right, any other comments? Tracy, Dr. Fletcher?
Oh, you don't want to hear from me.
Thank you, ladies, so very much. And with that, we will move on in our agenda.
And this brings us up to Sandy, and you're going to give us some information on the employee survey results.
Yes, thank you, Mr. Chairman.
You have the floor.
I appreciate the opportunity to share with you and the board. Thank you. I appreciate the opportunity to share with you and the rest of the board our 2023 employee satisfaction survey. We conducted it during the month of September. We had previously had survey questions that would change every year. And so it was really hard to look from one year to the next to see what was trending better in an improvement or trending worse as far as employee satisfaction. So we made a concerted effort this year to make the questions measurable from year to year. So for the most part, unchanging questions. And with that point, we developed a list of 30 questions for staff to answer. Also a quick and easy to respond to survey. Took about 3.5 minutes average to complete this survey so that we weren't taking time away from their important duties, but giving us the information we needed. We had 4 categories of questions that we asked to gauge their satisfaction. We were asking, how is PhD doing? How is my supervisor doing? How is my team doing? And finally, how am I doing? The how am I doing is more specifically my satisfaction with my job, my ability to promote into another position, my ability to get additional education, those types of things. Again, we had 30 questions, so this is just a sampling of some of the questions. When we asked an employee how PhD is working, we asked, are they working PhD is working proactively and efficiently. PhD tells my work group what it needs to know to do the best possible job. For team, my work group feels responsible for meeting its objectives successfully, and we maintain a high standard of performance. Each one of these questions was on a scale of 1 to 5. 1 is I strongly disagree, 2 is I disagree, 3 I'm neutral, 4 I agree, and 5 I strongly agree. So that's how we categorized all these. Were asked about their supervisor. My supervisor's willing to listen to my concerns and ideas, and my supervisor encourages people to give their best effort. And very importantly, I have confidence and trust in my supervisor, because that's one of those things where oftentimes employees don't necessarily feel confidence in the people that are leading them, or vice versa, their team that they are leading. And then finally, on self, doing my job gives me a sense of personal satisfaction. I enjoy performing the day-to-day activities of my job. And finally, I'm proud to work for PhD. An additional question we asked in that section was, I would recommend PhD to my friends or my family if there was a position that was open that applied to them. We had a great response rate. We had 84 out of 110 people, or 76% of our staff, respond to this survey, which is pretty incredible, actually, because surveys typically you don't get this much of a response. This percent includes people who responded to every single question. We had one question that many people did not respond to, which was what department. They were able to answer what department they worked in. The entire thing was confidential for them, other than potentially saying what department they worked in. So I don't know who answered what. I can see what each person answered as a total to see some trends there, because there were a few people who thought everything was bad. And then there's a few people who thought everything was good. So, you kind of knock out the high and you knock out the low and you get that average, right? So our final results with it were quite we were quite happy with our responses, actually. You can see the high, over half of everybody was even happy with satisfaction with PhD. So 65%, I think, is a good number. There's always room for improvement. We can look at what we can do to fix some of the things with this, but again, we can't make everybody entirely happy about everything, but we'll do the best that we can to make improvements there. Great number for satisfaction with supervisor. 81% of people thought that they were quite happy with their supervisors, which on the floor and sometimes comments, you feel like that's not the way it is in real life. But when they got the opportunity to confidentially say how they felt about their supervisors, it's a quite positive number. And their teams as well. So their team of coworkers and not feeling like anyone has, dropped the ball and they're having to pick up work for their coworkers. It's that they feel like they're working together for a concerted goal. And then satisfaction with the job. 72%, I think, is a really good number. Of course, people always want more money. Even though statistics say that money is not the reason that people come or leave a job, it's always going to be on the table as a point of topic. But I think, nearly 3/4 of our staff being very satisfied with their job is a really positive number. So just in summary, the current employees of Panhandle Health District are happy with their employer, their supervisors, their coworkers, and their own positions and opportunities. And our executive team will continue to look at opportunities to increase employee satisfaction in any way that we can. And if you have any questions, I'd be happy to entertain them.
All right. Questions, comments?
Yes, Annie, I was wondering, and I was trying to remember from before, is there what is the percentage of positions that aren't filled here? I know we touched on my first meeting and I just don't remember what that is. Is it?
We actually just this month had quite great. We're onboarding 8 individuals in January this year. So
Okay.
we have only have a couple of positions that are vacant right now.
Okay.
And many of those are temporary positions or minimal hours a week type things to help fill in.
Okay. Yeah, because I just couldn't remember the number. I was wondering, have you ever considered doing like a 360 review completely anonymous from an outside source? Have you ever considered that on a survey like this?
That option did come up in this look at creating a new system, and it's not something that we're opposed to. It will just take a little bit more time and development to get something like that put together. It takes a couple of cycles for a 360 review to actually garner good information.
Right.
Because that fear of saying something about my supervisor and they might find out about it. So because a 360 can't be anonymous, right? So there has to be a lot of trust.
Right, but I mean, if it was done by a completely anonymous outside company, if we did it that way, because see, here is kind of my thought. 65%. I mean, this is just my immediate reaction. I'm not trying to be negative, but it's just kind of like maybe there's some other information we need to root out. You know what I mean? Because 65% is saying just a little over half are happy with Panhandle Health in general. I mean, I don't mean to be cast a shadow, but I mean 65 to 65, right? And then when we know that 25 didn't even, participate, there's a higher chance that maybe those 25% might not be super enthusiastic. In other words, they might knock 65 lower.
Right. Well, and that's a great point. If I look at the questions specifically, it's a lot clearer. What we did include was a neutral category,
Mhm.
which is probably the change that we would make next year, is remove that neutral category, because we had a lot of people fall into neutral. Well, if they fall to the positive side next year, that will tell us a lot. But if they fall negative,
Mhm.
then that will be a concern
Mhm.
that we're not.
Exactly. I mean, so I'm just trying to, help Panhandle Health, because if there's a lot of, or a substantial percentage of employees who, like you were mentioning, didn't want to list their department, I mean, there's some hesitancy there. Obviously, they don't want to be identified. I mean, so in other words, that's why I think maybe to consider an outside group that's 360 completely anonymous, where people are assured no one will have absolutely any idea this came from you. What are you thinking? What are your thoughts? There might be a more accurate assessment, in moving forward, because if there's certain areas that survey could root out, then we would know, okay, this is where changes need to be made that will immensely enhance and make everybody happy, or 80-90% of people happy and enthusiastic. And that's why I wanted to come.
Dr. Butler, I see. So the group I used to work for, Austin Radiological Association, we employed a 365 for years and years. And it included everyone, including the owners, the senior partners. I mean, no one was exempt, from janitor all the way up to the president. I thought it was a superb exercise. I fully endorse it. It was totally anonymous, outside people. But probably the most telling and useful feature of that exercise was the free field. In other words, you have all these boxes, you check your boxes, and there's only so much information you can glean from that. But then you have the free field, where people can just write what their sentiments are. And the folks that would collate all of this information were kind enough to collate all the free field. And as Thomas Fletcher's reading the free field comments about Thomas Fletcher, it's a little sobering, even though in the aggregate I was a pretty good guy, but you get feedback in very subtle ways. So I fully endorse it. I think it's a superb tool. And I don't know what it costs. Well, it's not cheap. If you do it right, it's not cheap. But just would echo your sentiment there, Duke.
Okay.
Mr. Chairman.
Yeah, well, I think so. No, sir.
My question was this?
No, that's another topic.
Different topic, okay.
Dr. Bates, whatever your name
Yes, Mr. Chairman. So on that idea of 360, I actually went through the process last year of becoming certified in a moderator for 360 evaluation. So I'm a strong advocate for that. I've had at least 2 done for me over my professional career. And for my continued growth, they were invaluable. Yeah, I should have more of them. So I'm a strong proponent of them for sure. And the company I use is a non-for-profit company that probably does more, that I'm certified with, probably does more 360 evaluations than anyone in the world. In fact, they conduct these all over the world. And a very nice thing about the data, they don't only are they not only very confidential, and they're very positive in nature. It's not in any way a punitive effort. It's to gather information to really help that employee progress in their profession and use the data accordingly. But the only challenge with it is cost. With the company that I'm certified with, and I would never conduct those, obviously, for my own employees, but there's other people around the country that have that certification that can do that. But the cost of the 360 alone is $380. And you multiply that times 110 employees, that can be a little challenging.
It is expensive.
The thought that I have had is whether our supervisory staff we may begin at that level conducting those, but even that can be a little expensive. But I agree with Dr. Johnson and Dr. Fletcher completely.
Well, maybe instead of the 380, we might find another organization that performs them for a lesser cost. I mean, perhaps, that concept could be explored to determine if there is, a difference in priority out there, or costs, et cetera, that maybe might not be as expensive and still provide the information, I mean, because I think when it's anonymous, people will really tell you, if they think their job is certain, they're not going to tell you the truth. I've been part of surveys where I'm going, there's no way in the world I'm going to tell them what I'm thinking. As being a subject in that kind of a scenario. So that's why I just brought it up, because I've seen a wealth of information. It's like, wow, really? They feel that way. It's like, but you wouldn't get it unless it's anonymous. So maybe we can at least explore the concept or find out if it's there's a company that can or something.
Okay, Glenn, your turn.
Mr. Chairman, I was just going to say, it sounds like a 360 is an excellent tool.
Mm-hmm.
So why can't we incorporate that into our employee management here, at least follow their guidelines or their example on how it's done? I don't know if it's copyrighted or what, but if it's expensive to have an outside agency come in and the anonymity, yeah. How do you work that? I don't know.
Trust.
Well, yeah. I mean, the only way you're going to get the real answer is if it's outside.
They do it, and that's expensive.
That's the key.
Dr. Fletcher.
I had only one word, trust. It has to be outside. Otherwise, you're not going to get the truth.
Yeah, that's a good point.
By the way, one of the comments made about me was that I have to stop ranting about hospital administrators. So I stopped ranting about hospital administrators.
All right. Sandy is going to just briefly introduce the subject of the director evaluation. We'll do that in executive session at our meeting in March. Sandy?
Mr. Chairman, you just said everything I was going to say. In section 4, there is our new employee evaluation form that we instituted this year. The employee evaluation that the state employed was very user heavy. It took a lot of time and effort, and we adjusted our process so that every employee gets their review in November of every year.
On an annual basis.
On an annual basis, everybody has to get it in the month of November.
The probationary?
Except for probationary, so they would get it, and then they would get another one in November. As soon as, if they.
Okay, so is it like a 6-month interval, a 3-month interval, or what?
Well, the new
probation?
hires, the probationary, they do get a 6-month review. So then they would get a 6-month that might go over that November, and they wouldn't be due for the next November, or they might have one in January and get a review in June, and then get another one in November.
Okay.
So.
We should have done this in January. It's my fault. I apologize. But if you could get this information back to Sandy prior to our March meeting.
Oh, so the purpose of this is for us to evaluate our director here?
Well, you can use this as your starting point, yes.
Okay.
Are you going to send us something digitally?
I can certainly email you
Please.
this form digitally, and so that you can complete it, and any comments that you want to add, and then,
Okay.
yes, as,
So just be advised that we will have an executive session. And after the executive session and we summarize the results, then I will meet with the director following that meeting in March.
very good.
Okay, any questions? All right, have been anxiously waiting for your turn. Now you have it.
Thank you, Mr. Chairman.
So it's been a while since you've had a financial report, hasn't it?
Yes, ma'am.
New system, but same format as what we've had before in the past. We'll address cash balances first. So we ended December with $4,778,000 compared to ending in June at $5,445,000, a decrease of $667,000. Part of that is a result of the new system. We had, as of about a week and a half ago, approximately $500,000 outstanding in accounts receivable. Actually, that balance is more, but it's more current. But $500,000 related to aged invoices, and those were coming from state agencies that have not yet paid us. We're starting to see that money come through. So that was just an issue related to the Luma conversion. So I anticipate that we will see our months in reserves increase the next time we visit this in March. So currently, the months in reserves is 4.99, but when we back out the board committed funds and the restricted funds, the months in reserves is 2.84. If you add that outstanding balance of about 500,000 back into this, we're probably at about 3.66 months in reserves. So hopefully that will be higher when we meet in March. The other thing that we have not done that we typically do in this meeting, we discuss what we want to put into board committed funds. And I'm going to hold off on that conversation until likely March or April. Our budget to actual. Our licenses, permits, and fees and environmental is over budget by $59,000. $32,000 of that is related to food permit fees that we receive in bulk early on. So the other balance would be an increase in permit fees. Clinical services or health services is under budget by about $93,000, and that's related to staffing. We've been down in a nurse practitioner and other clinical staff, which also relates to lower clinical visits. General support, that would be death certificate related. Other fees, that is going to be, what do I have here? I need to visit this. I'm going to bypass on that because I want to revisit that and how that information is coming in through Luma. So I'll have a better report on that next month. Our grants and contracts, that's showing that we're under budget by about $370,000. Again, that's going to be related partially due to Luma because we are still invoicing some of November. We are just getting December's invoices out. And that's really quite an achievement. I'm really proud of the fiscal team. They've been working very hard. The projects and grants manual is somewhat cumbersome. And we had a meeting yesterday with the state, with the other health districts. And as I just said, we're invoicing through December, and the other districts are just finishing their October invoicing. So we've made some really nice progress. They've done great. Interest, if you remember when we did our budget season, I stated that I was going to budget conservatively on interest, not knowing which way it was going to go. It appears that I was a bit too conservative. Interest is over budget currently by $76,000. And we just have variances here for rents, other miscellaneous and donations, probably netting about $3,700. We are under budget in personnel expenditures by $584,000. That's related to staffing, open positions up through December. Operating expense, we are under budget by $137,000. Capital expenditures, under budget by $25,000. Trustee benefits, currently over budget by $3,000. So in total, when we look at year-to-date actual, we have an excess of revenue over expense by $32,000. We make our adjustments for our accruals, add back our beginning cash. That will bring us back to our ending cash balance as of December 31st. Are there any questions?
Well, you seem a little bit happier over this Luma situation than you did last time.
I just put on a good show. We have made progress. There's still a lot of progress yet to be made. We have policies and procedures to update to address the new system. We still have reports that need to be built. The main objective was to get some financial reports so that we could know our current financial position and also to go into our fiscal year 25 budget season. So it's slow and steady progress, but we're getting there.
Thank you.
Any other questions? No questions? This concludes my report, Mr. Chairman.
Appreciate your work, as always. We will take a vote on whether you want to listen to the director's report or not.
Doesn't look
May I
like
cast a vote on that?
action item.
All right, here's our director.
Yes, thank you, Mr. Chairman. Just a couple of items I wanted to go over with you today. And, first of all, our chairman, Mr. Bailey, and I have been talking about the possibility of providing some training to board members. We have a lot of new board members. And so we have put mostly, I know that both our chairman and Mr. Bailey have reviewed this. If you go to our tab number 6, you will see kind of a brainstorm of areas that we could provide this training on. I don't want this to appear remedial at all. We just do have a lot of new board members here. And what the thought is whether or not we should have a little snippet each time we have a board meeting. It would be great. I know the Idaho Association of Counties, Mr. Bailey informed me when you're called as a county commissioner, there's a 2-day training you go to, and then training throughout that period of time that you're at least available to take part in. And so our thought was we might do a 5 to 10 minute snippet at each board member to cover these items here with our board members and then have a discussion, rather than trying to get the board together for an all-day training, for example. So I'm really kind of opening that up, Mr. Chairman, for discussion with our Board of Health members today. And as you look at this, is this sufficient? Are there items you'd like to add to this, or how you feel about that idea of training altogether? And I would love to get some feedback on that, Mr. Chairman.
Okay, you heard the question.
Mhm.
What would you like to comment? Yes.
Yeah, I'd welcome, that during the meetings as well, for sure. I think it's a great idea. Because to reserve a day or two for everybody's schedule to match, it would not be easy. So I think that's a perfect use of the time.
Okay, any other comment? What would you? Do the employees want to evaluate the board?
Mr. Chairman, I just had a question. So Don, are you recommending that we have a discussion out of these, on each of these 3 subheadings? Each time we meet as a board?
Yes, Mr. Bailey, that is my suggestion, and.
Because there's an awful lot of things.
Yeah,
covered
and-
here.
You know, some of this stuff, some of these items won't take too long to go through. I think other ones would obviously have more discussion. And I wouldn't suggest that not just limit me leading this discussion. It would be nice if board members would take on some of these topics and come prepared to review some of these.
Yeah.
I like that idea. I think we have some staff here that could also moderate a discussion on some of these topics.
Thank you.
Okay, any other comments on this? We will pursue. All right.
Thank you, Mr. Chairman. Also, you will notice our lunch is a bit leaner than it's been in the past. In the past, we usually spend a couple $100 on lunch, and usually more than half of it goes uneaten by this group. And so we have limited it to more snacks, and several of these snacks we can actually, if not used, we could bring them to the next board meeting. So I want to make sure that the board, Mr. Chairman, is comfortable with that. Again, this array you see ahead of you costs around $70 as opposed to a couple $100 of food that goes uneaten by our board. So I'm just reaching out to our board to see if they wanted to continue with the lunch as you see it here today.
Fine with me.
Yeah, pretty good. Thumbs up.
I don't eat
Works.
commercial food.
Works good for me.
That's good. Okay, very good. Thank you so much.
Keep in mind that those who are watching on the screen are going to have to come here if they want the food. So starve away, Tim.
All right, Mr. Chairman. And then also, I wanted just to inform you, because we've been doing this in all of our districts, if you turn again to tab 6 on the second page, I thought I would provide to you a list of services that we are providing to our schools. You'll remember in the CHA, there was a significant concern about youth services. And so Kim Young and also Katie Smear, who oversees our opioid settlement funds, the 3 of us over the last couple of months have visited with just about all of our school districts in the 5 northern counties and simply said to them, we have some funds available to you if you'd like to use them. How could you best do that? And you will just see, I'm not going to go through all of these with you, but you will see a list of services that they have chosen to use within their school districts. And this is mostly funded through our opioid settlement funds going forward, as again, addressing what you saw in your CHA regarding the issue with youth services. So, Mr. Chairman, I just wanted to present this to you that we're actively involved in our school systems. We really have a strong, we always share with all of these services as best we can, parental involvement on all of these. And that there's a number of reasons why that's important, not the least of which will be more successful if the families are involved in these, not just the students. So I just present that to all of you, Mr. Chairman. And then finally, an item that I did clear with our chairman to share with you, an item that just came up recently, just really, we got answers on it just this week. As you know, as a public health agency with House Bill 316. We were, at least at that time, verbally, if nothing else, more associated with the state. With House Bill 316 a few years ago, it was made it clear that we are a separate political subdivision. Well, what that brought, we found we're here very recently, is a section within the federal government called Section 218, which essentially says, if I'm getting all of this correct, and Christine, please jump in, you're more of an expert on this than I, but essentially what that means is if a public agency has a retirement system, that the employees of that organization could potentially opt out of Social Security. Now, this wasn't an issue when we were tied to the state, but now that we clearly are separate, what will need to happen here very, very soon is that we will need to do a referendum with our employees, and if a majority feel they want to keep Social Security, and again, as you know, that's that 6.2% that's taken from our paychecks, then if they feel like, yes, we want to continue, then we'll simply continue. But there is a possibility that a majority will say no, that I would prefer, whether it is I just want more food, more money for food on the table, or if I want to invest that in my PERSI or other retirement. If a majority said no, then we would no longer be withholding Social Security from our employees. This is something that's been around for quite a long time, but just came to a need for us with our departure from the state. So I'm just informing you of that. I just felt it was kind of an interesting change that we're seeing. And Mr. Chairman, that's the end of my report, and I'm happy to take questions.
Well, you are saying, though, that there wouldn't be the option for individual decisions.
Thank you, Mr. Chairman, for the question. There are some states where they can, whoever chooses to continue with Social Security can within a government organization, and those that say no. I'm not aware that that's true in the state of Idaho.
That's going to be the hiccup. So be it, sir. Okay, anything else for you?
No, sir.
Thank you for coming back to us after a week's vacation last week.
Well, I'd like to say it's nice to be back, but I am happy to be back in the health district.
You mean you had more fun on vacation than you did being here at work?
Mr. Chairman, anytime I can be with any of my 14 grandchildren is a great day.
We'll take your word for it.
Thank you, sir.
Thank you. Anything else to come before this board at this time? Yes, Glenn?
Mr. Chairman, I just had a quick question on this list of the Panhandle Health District Officers Youth Prevention Services in local schools. I'm not seeing the SPAN program here. Is that something that's being offered to the schools, or? I guess I would.
Mr. Chairman, are you referring to our SPAN suicide prevention
Correct.
within the schools? We are not. Now we have of course, a SPAN chapter here in Kootenai, and we invite anyone, and we, including kids, to participate. And we do get quite a few high school age children that participate in our walk each year. So we do our best there. In York County and Dr. Fletcher's County, in Bonner County, there is a chapter of a suicide prevention that's very active. And there's another one in Benewah County, and in Shoshone County, they have the SAVE Coalition that does very much similar work.
I think
So
that's covered then.
I wish we could do more, but it's kind of what the resources allow us.
Just one question.
Yes, sir.
Anything else to come before this board? If not, we are adjourned. Thank you for being here. Good meeting.